Well, good morning and welcome again. Yesterday was really quite exciting, enthusiastic, provocative discussions, and I expect we'll have more of that today. No particular announcements, so we'll get started with the first session. We're finally getting around to talking about care coordination. At least as part of as a scheduled topic for this session. So David Labby is going to facilitate.
So just on reflecting on yesterday and what we're doing today, it seemed to be looking at the agenda, and I assume this was the intent of the organizers, that yesterday was really sort of setting the stage with policy and thinking about who the population is and how you would identify them in risk assessment. And today is really about thinking about the system that we're talking about. So this is supposed to be a conference around children with special healthcare needs and the system that they need. So these are kids with special needs, and they probably need a special system. And today we are talking about what that system looks like. Clearly, a key part of that is care coordinations come up many times. We talked yesterday about how the ultimate care, the default and the ultimate care coordinator is the family. And Dennis is going to talk a lot more about sort of the family orientation. Lots of interesting questions were raised yesterday. What's the role of the family? How do we engage the family? And how do we even perhaps pay the family for doing the work, which is so critical? Alan is going to talk about a model for the system of care that he has put together for adults, and someone who is really focused mainly on adults for many, many years. The similarities between what we are talking about here and the conversations that have been happening for a long time on the adult side are very clear to me. We have special populations for whom usual primary care, even the best usual primary care and the best usual medical homes probably will fail, and so we need to build special systems. Chris is going to start us off by talking about care coordination as one of the elements. What is care coordination? But really, I think the question for the day is, what is the special system that kids or populations with special health care needs need? Just want to say one more thing. This is a real challenging conversation in the context of the conversations we've been having, really started by pediatrics over 25 years ago around medical home. When I started working around medical home around 15 years ago, promoting medical home, the belief at that point was that we were creating team-based care that was sort of pluripotential, could do anything. Bring us anybody, we will take care of them. And so we built sort of generic teams that could do everything. Well, that's what we thought. In truth, I think what we've learned is that's a model that won't work for many populations, and we need to rethink medical home, that there may be subspecialties or sub-teams that work within medical homes that work with special populations. Certainly that's what we are doing, at least I've been working on for the last number of years on the adult side. As a coordinated care organization, we have a lot of foster kids, and that's what we're doing actually with our foster kid population. We're taking a model that was developed by one pediatric practice with a special team for foster kids, and we sort of looked at where our population of foster kids are, and we went to the organizations with the largest ones and said, you have many foster kids and you're not doing anything coherent with that group, which is a very complex group. So what should you do? And we have a collaborative that we just launched around creating special teams. So what is the system of care that we're talking about is going to be much more of a complicated system of care that's going to have to figure out how it deals with numerous special populations, not just adult special populations, but kids special populations. And then one more point from yesterday, and actually talking to some of the organizers is really interesting. When I first heard about this conference, it actually said that we were going to be talking about children with complex medical needs. And I didn't really notice until yesterday that the title has now shifted to complex healthcare needs. So given Rita's presentation yesterday about complexity, the complex social, we really need to broaden our conversation, I think, and think about if we're dealing with children with special healthcare needs, that includes children with special, who are complex on the social side and on the behavioral health side. Reed Sulik yesterday sort of raised the question about shouldn't we be talking about behavioral complexity? And if you think of a biopsychosocial model, you can have complexity in multiple dimensions. So how do we create, so the ultimate challenge is, how do we create a system of care for complex kids that is responsive to the biopsychosocial needs? And that's a real challenge, because I know from our experience, certainly in Medicaid, we have lots of kids with special health care needs that are not medical. They're mainly behavioral and social. And we hear about them from the schools, we hear about them from the communities. And that's a different kind of problem to solve than solving a problem for kids with special medical needs who might have some social needs and might have some behavioral health needs. So I think that's the challenge for the day. And Chris is going to start us off giving us a framework for thinking about care coordination, which is a key part of the system that we're trying to build. Thanks, Chris.
Great. Thank you very much. Thanks so much to Ed and the foundation. And it's a super big honor for me to come and be the first presenter to talk about care coordination as a specific topic this morning. I want to start with stealing a quote from one of my favorite pediatricians, Dr. Peter Szilagyi. It's all about the children, remember. I think we can add, it's all about the children and the families. And I think if we ground ourselves in that as we go forward to design systems and tweak systems and really make the best systems we can while pursuing the triple aim, we'll do well. So that's why the topic of my talk is partnering with families to support integration of care. I might say using care coordination and care planning. I'm going to talk about the central role of children and families for a minute, although I know Dennis is going to do a lot of that, so I'll try and keep that short. Talk about why are we stressing care coordination so much in healthcare processes for kids with complex needs. A little bit about the evidence that we have and what we need, although you can read about that in some of the documents that I'll talk about. The difficulty of care coordination in particular for children with medical complexity as opposed to other populations. Some solutions about what works and what might work, and then finally a nod to policy and payment, although that's also going to be discussed later today. So I have to give you a warning. The presentation contains 19 question marks. We're learning a lot about care coordination and care planning and really are achieving a lot of insights about it. But just like any good scientific process, anytime we look at it, we create more questions than answers. I also want to start by putting the references at the beginning. Most talks have the references at the end, but these are really, really important, and these are some of the things that I referred to when I was making this talk. The most recent is a publication I'll call out at the bottom. Meg Comeau is one of the authors who I see in the audience today that was just last month about care coordination. Here's also my favorite definition of care coordination, written by 2 out of the 3 people in the room are here too. Pediatric care coordination is patient and family-centered, assessment-driven, meaning you look at the needs of the family, designed to meet the needs while enhancing the caregiving capabilities of families. That's key. It addresses interrelated needs, which David pointed out. Behavioral, educational, social is in there to achieve optimal health. And I think that's probably my favorite definition, even though it's a little bit long. I'm a very visual learner, and how many of you have seen a care map designed by a parent about a kid? That's great, most of you. I hadn't seen it before about 2 years ago, and when I saw my first one, I said, oh, that's why this is so complicated. This was actually anonymized. The red circle in the middle was a picture of a patient that's cared for at our institution who I don't know, but he's an older adolescent with a complex bunch of problems over here on the left side. Medical stuff is the purple in the upper left, but then there's a lot more than that. Well-being is probably the most important on the lower left. Home environment, which has a huge impact, probably much bigger than any medical care we can provide. And then insurance coverage, which makes the rest of it possible. But I think it's instructional for us to think of all of our complex patients as having a map at least as complicated as this that we need to pay attention to. It's one reason care coordination is such a huge challenge. From the family's perspective, especially for children with medical complexity, it's a lot more than help in arranging appointments. Sure, that's a good thing, and we're good at that, but we need to do more. The other thing that's important, and thanks to Eileen for this, to helping me focus, Eileen Forlenza, parents are the ultimate coordinators. They do most of the work regardless of what else we do successfully or not. And so really our major goal is to support and enhance the roles of parents in taking care of their kids. And when I say parents, I mean caregivers in general. But also to do things that we can uniquely do. Doctors can do things that are different. Nurses can do things that are different. Social workers can do things that are different. Community health workers can do things that are different from things that parents can do. So why is it so central? Well, I don't have to convince you that the care is complicated. The complexity continues to increase. It is, I like to think sometimes it's less fragmented, but in reality for a lot of kids and families, it's still pretty fragmented and needs someone to pull it together. There's also an increased need not only to make appointments and do the nuts and bolts, but to navigate the rest of the system, as I mentioned. The other thing that we've acknowledged, and hopefully we'll talk about more later this afternoon, is that fee-for-service is still the predominant method of payment, which is actually a disincentive, unfortunately, for well-coordinated care in a lot of cases. One product of that also is the communication between all members of the healthcare team, patients and families, and the community is suboptimal, and in very few cases is it reimbursed at all. The triple aim helps get us there on a conceptual level with the idea that integrating care, which includes care coordination as one task, will improve the quality of care while at the same time lowering costs, but probably most important for kids and families, increasing met needs. And the nice thing is when you look at care coordination outcomes, probably the strongest outcomes that we have an impact on are meeting the needs, regardless of whether we save money or not. I'd like to talk for a minute about care coordination, as we a couple people referred to yesterday, not as an end in itself, but as a means to an end. It's really a tool. I have a little bit of a baseball analogy that I kind of made up in the middle of the night about a week ago. A care plan is a ball. Care coordination is how to throw a ball. But integrated care is the team playing with the ball, throwing, catching, batting, all that other stuff. Really, integrated care is what we're pursuing. Developing a care plan is really hard and time-consuming, but it really needs to be assessment-driven. What are the needs of the patient and family related to the rest of the system? It should be shared between the family and the care coordinator and have some input from the care team so that everybody can use it. And it needs to anticipate the needs of the patient and family and potential consequences of things that happen. So it's a pretty big deal to make one. However, you need a ball to play ball. The care coordination is using that ball. Traditionally, the care plans are not used by all members of the healthcare team, but that's kind of level one care coordination. Integrated care is really what we're striving for, and if a care plan is useful by multiple team members, we can actually do that and eventually hit home runs. Indulge me for a second. So the other thing about integrated care is that you can get feedback and change the care plan on a regular basis. Here's an example of a care plan from a moderately complex patient in our special care clinic. It's 6 pages. Right now it's 1,766 words. This is 1 page. You can see it's really, really long. We need to make our care plan shorter because we've not actually done it for a lot of patients in a systematic way. We'll get there, but we need to shorten it. They can be simpler. A couple people who I have worked with in this room have developed some care plans that are very simple. What's the problem? What's the status of the problem? What needs to be done about the problem? Who's going to do it? And when are we going to follow it up? So we need to get somewhere between what was on the last slide and this. What's the right balance of detail versus what you can use tomorrow? I would say probably what's on this slide is a little bit better to start with, but we'll go from there. So what does the care coordinator do with a care plan? Well, as I mentioned a few slides ago, they're one of the experts on the team with some unique knowledge. Depending on the needs of the patient and the family and the background of the care coordinator, their unique knowledge can be different. But they do have some expertise in doing their job. Ideally, they have the personality and the skill set to be the glue between different components of the healthcare system. And I have to admit that doctors, although we try, don't do such a great job of care coordination. We have neither the training nor the scope of knowledge about how to coordinate services, although we do what we can. And again, the goal, increasing met needs. A couple other things about coordination and integration in this relationship. I mentioned it a little bit ago. It's hard to get team members to use the care plan to harmonize the care they provide. They need to have input in the beginning of the care plan, which is one of the reasons that it's actually operationally pretty hard to do, to get the cardiologist, the GI specialist, the mental health provider, the social worker, the parent all on board. But in order to create a really good care plan that's useful, everybody has to have input. I know many of you don't like seeing documents you've never seen before and never had input before that have some bearing on the people that you care for. And in order to get your buy-in, you're going to need to have some input. It also requires a lot of work that, again, is not reimbursed in the current system. So we have a little ways to go with that. Just a minute on care coordination versus case management. The definitions are kind of all over the place for care coordination. In fact, I've seen care management even more recently, which kind of makes things even maybe a little bit more confusing. Just to point out what I feel are important differences, the care coordination, as I said, is a tool. It's a function of a direct care team as opposed to one person. It's focused on the needs of the patient and family. It's based on an assessment, as we talked about before, and it tends to be broader. Case management is typically more topic specific. The case manager might be a person who's outside the care team, for example, someone who works for a payer, is focused on resources and resource allocation, which may or may not go with meeting the needs of families. It's often based on criteria. If this patient has X, Y, and Z complexity, they get X, Y, and Z resources. And it typically is narrower. Now, again, this is traditional, and things have changed, I think, for the good in general. But just to call out kind of some traditional definitions, and then we can kind of go from there as time goes on. So here's a couple of questions. We talked about how important care coordination is. How to get the members to a common understanding. It's hard. It's a heterogeneous thing. It's an open question for discussion. I don't have any answers, but I think we should talk about that. And then more importantly, how can we change the culture of team members so that team members all have input and really are interested in having both input and working with care planning and then eventually integration of care. Couple minutes on evidence. We know a lot from the adult literature because it's easier to study. There's a lot of disease-specific outcomes and the epidemiology of adult chronic conditions in general are larger numbers of people with more prevalent conditions. So you can look across conditions and look at specific outcomes related to those conditions. Kids, a little bit fuzzier because there's the kids with complex needs, you can't have a one-size-fits-all kind of model. We can look at sort of common outcomes like ED visits and inpatient readmissions. Sure, care coordination has some impact on that, but really the biggest impact is in family-centered care and met needs, which are sort of fuzzier outcomes as a lot of people look at them. Care coordination also directly affects processes more than outcomes, so it's harder to look at outcomes when there's a lot of other variables in the equation. Most of the good care coordination measures are survey-based because they ask parents and stakeholders kind of what happened. It's really hard to get any evidence about care coordination from administrative data. The data just don't really support looking at things. But most population-level data sources look at resource use and don't focus on the process, so it's harder to get outcomes from there. There is some progress, however. The ARC Care Coordination Measures Atlas continues to be updated and has some good care coordination measures in there, again, mostly survey-based. I'd also like to call out the work that was done by Rita Mangione-Smith and crew in Seattle to develop more measures of care coordination, which are now actually getting out there, which is nice. A couple of questions about measurement. One thing that we don't know is how to drill down about care coordination and processes and outcomes. What kind of care coordination is most helpful for what kids under what circumstances? Most of the evidence that we have are from fairly large programs that include care coordination as part of a bundle. But knowing, okay, which kids need what is a little bit harder to figure out. And finally, I keep going back to I don't know if it was originally developed in internal medicine or family medicine, about ambulatory care sensitive hospitalizations. That's a really cool thing in terms of linking care to outcomes. We might want to develop care coordination sensitive outcomes that we can look at specifically in the context of kids. I haven't heard of a term like this. It just sort of came to mind last week. Here's some challenges. We talked about the 5 Ds yesterday. Actually, 4 of those Ds were created by Chris Forrest, with the 5th added by Tina Cheng, and we just all put them together in the APA Family-Centered Medical Home Policy Statement about 5 years ago. But the 2 that are most important for care coordination are the differential epidemiology. I already referred to that a little bit, with kids having a greater number of less prevalent conditions, also with a longer time course that David raised as a point, and I think is really, really important. The other one is dollars, with children with medical complexity tending to be poorer than other kids, as well as the 50-plus state Medicaid system that we need to deal with, where adults have a Medicare system that's relatively uniform across the country. Those are, I think, 2 of the biggest challenges for care coordination among those 5 Ds. So we need to take a non-disease-specific approach to care coordination. This is where the skill sets of care coordinators and care coordination teams are really important. Care plans need to be updated more frequently because children's needs change over time. The skill sets of coordinators just need to be a little bit different, and maybe they need to be a more heterogeneous bunch. We need to pay attention specifically to social determinants writ large, specifically consequences of poverty, which is probably the most important social determinant of health that impacts on the health of these kids. And there is going to be more variability between states, and so one care coordination model that applies in one state may not necessarily apply to another state, depending on the conditions and the resource availability in those states. This is what happens. Another challenge. There's lots of silos of coordination. You have the GI coordinator, you have the mental health coordinator, you have the community coordinator. Our job is to build covered bridges, which are those things in between the silos, so that people actually can get the care that they need. I think the farm is from the Midwest. The covered bridges are from Vermont. So anyway, took a lot of money to import those. I needed to write a grant. Another thing that families see is there's multiple care teams. Each has their own point of view. Some of them are high functioning, some of them are not high functioning. Some of them are collaborative, some of them are less collaborative. Each may have a care coordinator. And so you wind up with this on a particularly bad day. I have too many care coordinators. I need someone to coordinate them, honestly. So. Another challenge is that although we talk about care plans, in reality, care plans are hard. They take a long time. They're not reimbursed. And so care coordination is often very ad hoc. The other thing is, even if you do have a plan, kids don't often behave according to the plans. So that even the best laid care plans are useful most of the time, but not necessarily all the time. So we need to think and do better about sort of flexible care planning. The other challenge is in transition to adult care that we should spend some time talking on as today goes on. Parents I know that have gone to our adult hospital, even those that are really good at navigating the system among multiple adult subspecialties, really feel like a round peg in a square system. It just doesn't work that well for them the way we have it right now. And we know a lot that we should do to fix this. People have actually done some academic work on transition. There have been several funded projects. Got Transition is one that's great and has a really good website. But a lot of the time it just doesn't happen. We know what we should do, but we just need to execute and do it. Here's a few solutions, though. I've talked about a lot of problems. If families can get a primary care coordinator, not a primary care coordinator, but a primary care coordinator, they are often based at the medical home, which makes it even more confusing. And there needs to be some face-to-face time with parents and the ability for that, whether it's within a visit or outside of visits. Their biggest job is to coordinate across the continuum of care. And they need to have the skill set to talk to different organizations. This is a hard job. But something like that could work. Parent support and training in care coordination, we talked a lot about that yesterday. There are curricula, they exist, they work. Some Some of them, again, have been developed by people in this room, which is really nice. And parent-to-parent networks have been there for a long time, so that can be used as a tool as well. Another solution is specifically from the organizational literature that actually came out in the last American Academy of Pediatrics statement on care coordination. It's called relational coordination, and it's a skill that we don't pay that much attention to. It's essentially keeping in mind what the strengths and the relationships are of the different care coordination people and taking advantage of those to make a whole. A primary care coordinator could do that. We need to take advantage and have policies to enable us to take advantage of non-degree focused care coordinators. Some may be based in the care setting, for example, a family navigator. Some may not be based in a care setting, whether it's home visiting, which actually is reimbursed and fairly strong in some settings, community health workers, peer navigators, much like the parent-to-parent thing. The challenge about non-care setting-based care coordinators is how to communicate best with the rest of the system. This is hard. One thing about sort of your greatest model in the world, again, coming back to this care plan, is that resource-intensive care coordination solutions are hard to generalize, hard to sustain. Does that go off the end of the slide? Good. It was supposed to go off the end of the slide. So we have just too much to keep track of. Couple more questions. Okay, so if we have these care coordination resources, who gets them? I don't want to be a case manager here, but we need to sort of fit the need to the kid. And actually, Simon's work at Denver Health that he presented yesterday is actually a really, really good start on that. And then finally, how to include social determinants of health. We're on the way conceptually to that, but we need to execute that. Just a couple slides on policy and payment progress, and then I'll finish. We talked about the fee-for-service model. If you do more, you get paid for more, except when you don't get paid at all, which is usually care coordination, especially care coordination paid for, care coordination provided by patients and families. Care coordination isn't really task-based. It ends up being task-based when it's really reactive rather than proactive, but it shouldn't be. And then fee-for-service is single site-based. Typically, one site does a job, you pay them, where care coordination really in the best setting is across sites. So it's really hard to figure out how to pay for that. One clue is actually some population-based, maybe not fee-for-service stuff. One thing that we have in Colorado is the state Medicaid is divided up into several regional care coordination organizations, or RICOs, almost sort of like a mini Medicaid ACO. A couple of the RICOs have delegated care coordination. They'll give $4.50 per member per month to practices to provide actually a very rigorous, documentable list of care coordination services for kids that are attributed to that practice. And when you do the math, that will actually enable you to pay for one full-time equivalent nurse-level care coordinator for roughly every 100 children with medical complexity, if you assume that they're about 6% of the Medicaid population. So that's actually approaching doability. There are other states that were mentioned yesterday that also have some sort of payment for care coordination on an ongoing basis. And so we're actually starting to look at sustainability, and that's kind of nice. Questions about care coordination, who can do it and get paid for it? We talked about that. Parents do the most. How do they get paid? Although they don't get paid right now. That's why not is in quotes. And it also cuts across service sectors. So who's going to get paid for what when? That's a big question, and we can talk about that for a lot. I have no solution at this point. So to close, I will have my holiday wish here. This is my wish list. Where would I like to be in 5 years with care coordination? By 2021, every child with medical complexity will have a care coordination team, including a family navigator and other appropriate non-physician professionals, to support children and families, to promote their met needs, to promote the integration of care, not just the coordination, to formulate, implement, and update a practical, hopefully not too long, shared care plan, and to use the services efficiently. We need to pay attention to service use and cost. The team will be adequately paid for through non-fee-for-service methods that are portable between care settings and payers, however that is, and will be informed by enough data to determine which services are needed at which time and enable planning for the needs of other similar children in the population. Every kid is their own kid, but we need to be able to use data to generalize what we do for the next kid. So let's get started. Thanks.
Okay, so I'm Alan Glasshoff, and I formerly co-directed a program called Stanford Coordinated Care, and my new gig at Stanford is I'm a director of workforce transformation in primary care. And I'm going to talk a lot about workforce today in my talk, but also designing how we designed a program from scratch using different techniques that I'll go into. Rather than say, what's the current payment system and how do we make it fit within that, we started from total scratch. What would the system look like if it were designed to actually meet the needs of the people intended to be helped by it? And then had the luxury of working in an environment where we worked with Stanford as a self-insured employer, so that they were able to pay us any way that we could come up with it they would agree to. And that method was capitation. So we receive, a chunk of money for being the primary care home of complex adults. Our youngest patient is usually adolescents who are starting to differentiate from their parents. The type 1 kid at 15 who is telling their mother to bug out is the perfect patient for us, actually. But, and I could tell stories about that. So, we heard yesterday briefly, there was one mention in the first talk of the day about, we use terms like super utilizer or, hot spotter, those kind of terms. And we're coming at it from, that the patients or the kids in this situation, or kids and families, are burning too many resources, and what can we do about that? So what it turns out, patients don't really identify with those terms. They don't see themselves as super utilizers or problems necessarily, though they understand that the problems that they're dealing with are in fact their own problems. They don't like the word managed. They don't want to be either case managed or care managed. They'll manage themselves, damn it, they say. But they will, in fact, they like our support. So we actually call it care support, is the term that we use for this. There are a lot of other words they don't like. And there was a great article by Murray Ross, who works with Kaiser, that's called From Our Lips to Whose Ears, where he did 6 different focus groups around the country asking, what do you think of patient-centered medical home? And the answer was, I've already got a home, or don't you put me in a home? Those were the kind of responses. So words really matter, and so we support our patients, we don't manage them. We do manage their care. They'd like a lot of assistance with that. But when you think about the whole reason this work is gaining traction right now, it's really about the money. That there's a lot, when you can see data that says 5% of the people cost 50% of the money, or we saw yesterday 1% costs 38% of the money. And the first question that comes to your mind is maybe we could do better with that, and that's what created kind of the rising movement around this work. My first, complex case that I understood, got involved in post-residency was when I opened a practice in rural Humboldt County in California, and this retired plumber comes in with end-stage heart failure. His heart kind of beat about that much, and I asked him what his goal was, and his goal was, I never want to be admitted to the hospital again. I hate going to the hospital. So what I did was I saw him every week for the next year, and I would wrap his legs with dressings to keep the fluid out, and because he came in with weeping sores and was always at risk for cellulitis. I managed his Lasix up and down. I drew labs every week, creatinine up, creatinine down, Lasix up, Lasix down. And a year later, he actually died sitting in the sunlight in his backyard on a beautiful day with a smile on his face. my reward for that was getting investigated by Medicare for overutilization, though when I sent the notes in, they backed off. That was good. So when you think about cost, and we're dealing, we're dealing, and especially in the kid space, with a lot of very activated parents if we're fortunate. And then in some situations, you're dealing with really sick kids without activated parents, and that's much harder work. But the core thing you need is trust. That you can say, well, we can't do that, or I don't think that's a good idea, or I don't think in adults you don't need that MRI, even though the athlete got it yesterday. And what it turns out, there's a big trust problem in the U.S. And I have this slide up here, and it's obviously too small font to do much with. But if you look at it, you can see, they're asking a question: are the doctors in your country trustable? And then they're also looking at, Press Ganey or other CG CAPS levels of surveying being done around, the patient experience is the term. And in most of the world, Switzerland is number one in trust, number one in experience. Denmark is number two in both. The U.S. is third in experience. And I work in an environment where we do beautiful buildings, just cascading waterfalls and piano players in the lobby, and it's extraordinary. But the U.S. is 24th in trust, and we're the only country in the world with that gap. And then we're wondering why, the patients are saying, why are you not giving me that test? And why are you trying to restrict what you're doing? And you can't even begin to have that conversation unless trust is what's built. And you have to actually earn trust. You can't be granted it. So what we did in our program was start by interviewing 34 patients who fit the profile of people we were targeting. They were employees or dependents of employees at Stanford, and they had complex chronic conditions. And we used a methodology that grew out of the Stanford Design School and also spawned the company IDEO, for those of you who know it, where you basically open-ended conversation, very deep conversation. We interviewed the people who were doing well and the people who were really struggling, what's called positive and negative deviance. And what we came up with is this from and to setup. The patient said, and this I think applies really well to the families of little kids, that they felt often alone, forced to be the organizer of things that were almost impossible to organize, that often they felt more studied than cared for or listened to. They were presented with lots of facts, but not how to actually do things, the skill set they needed to do okay. They were passed around from specialist to specialist, and it's not unusual for our patients to have 7, 8, 9, 10 specialists. And they were stalled in their life because they couldn't, it was almost a full-time job. Either it would be for the parents in this situation, for the patients and their families and caregivers in the adult situation. And it was very resource intensive. So they were, as they got sent the EOBs, explanation of benefits, on their thing, and they saw it costs that, it was an added pressure they didn't need to be thinking about. And we have speaking of words, we use this word all too often, which is called skin in the game. And for the patients I see, it's like a horrible image. They go, is it my arm? Is it my foot? What are you going for? Right. So, and then what we came up with was a specific model that I'm going to go through now. And we do an evaluation of every patient on intake. And intake is a 2-hour process, that an hour of which involves the physician or clinician. It needn't be a physician. It just is because we take call at night. And it's actually a tool that we borrowed from David's world at Care Oregon, before he was at HealthShare Oregon, and we changed it slightly. But basically, don't assume you know what the patient's issues are, right? You have to find out what they are. And David's work sorted people into 5 things, and we combined the medical status and health trajectory into one. And so complex kids who have got dealt the hand that they got dealt, either from birth or from other events that followed birth. Basically, they live in the bottom left-hand corner, largely, very complex conditions that would stagger anyone. And then if you superimpose depression and behavioral health issues in the family or in the patient on the bottom right, lack of social support, kid with all those problems who's in foster care and not getting good care, or what we see in adults, probably the most predominant thing is the upper left. It's not about access to care, it's about trust. That it's not uncommon for us to see a patient with diabetes out of control, A1C of 14, who hasn't been seen in 2 years or taken a single medication. Well, why are you doing that? You're cutting off your nose despite your face. And the answer is, I hate all of you, basically. You've turned me into an idiot. I can't, you don't respect what I think, those kind of things. And so they just drop out to their own detriment, but they didn't feel like they had a choice. And we figure out which of these domains are in play and then help design a specific care plan around it. We also do a thing called the patient activation measure. How many people have ever seen this before in the pediatric world? So quite a lot of you. There is a parent caregiver version of this, because you can't ask a 3-year-old to fill this out. And the same is true at the end of life, because for elderly, it's more the caregivers than the demented senior that fills it out. And you can see, there are 4 levels, there are 13 questions. The questions build on difficulty as you go up. There are issues using this tool because, unfortunately, it's proprietary, though the woman who designed it was forced to divest it. She was at the University of Oregon. Judy Hibbard is her name. And she wished it weren't proprietary, but the company that's using it is charging money for it. Nevertheless, we think it's a really valuable tool. And you can see the population spreads in an average population. If you're working within the safety net, it skews left. At Stanford, it skews radically right, which is an interesting thing. I'll show you our data at the end. And what you have is a way to kind of figure out how activated is the family unit and what problems are they facing. Those are the last 2 slides. The key thing that we do is focus on self-identified goals of the patient and family, not our goals. So the notion of developing a care plan is based on where do you want to be in a year? If things went well, what would it look like to you? What's success? And then help you get there. And it really means biting our tongue very often about things that we think are important, like your cholesterol is 400 and your A1C is 14 and your blood pressure is 200 over 120. Because we found that if the patient isn't engaged and trusting us, we're not going to make progress on those things, even if we care about them. We do this in a team manner. So this is typical primary care, which is the cup runneth over of the provider. There's a little bit of a care coordinator doing something. There's a nurse involved. And then the 3 roles at the bottom usually are not present. Versus this is what ours looks like, where there's distributed parallel work, the doc is not the bottleneck to everything. And all these people are members of the team. The key of it is how we use medical assistance, which, our patients' problems are usually medical more than homelessness and community-based things. But we've discovered and I think fully demonstrated that medical assistants are capable of a huge amount of very effective work, even though they only had a high school degree. And there are often people, but for their birth situation and the experiences during adolescence, would have gone to medical school or could have gone to medical school. It's not an intelligence issue at all. We give them a panel of patients, and it's usually, in our world, it's about 100 is the number. A single provider works with 4 of them. Each of them work with multiple providers because the team has to be able to cross-cover and interact. But the key is empanelment, and then we can measure performance off of that. Their jobs include coaching, healthcare coaching, and they're heavily trained in motivational interviewing. They advocate for the patient across the system. They do the usual MA stuff, give immunizations and blood pressures and room people. They scribe the visits so that they stay in the room throughout the visit, meaning it's not, here's a person who doesn't really matter and I'm going to have them do a few tasks for you, but rather, this is a member of the team that was part of the crucial conversation. They do all the outreach, they do all of the population health stuff, which it takes a lot of time in primary care. Our numbers are, we're 90th percentile across the board in HEDIS, we're 99th percentile in Press Ganey. based on this. And the whole thing, going back to what Richard Pan talked about yesterday in his question, is it's all about relationships, but it needn't be relationship with an individual. What we've discovered is if you really do the team thing well with a major person most of the time there, you can succeed with this. And I would say the way to measure it is to ask the patients. There isn't a separate way to do it. We train them, we have a team meeting where the doctor job is shutting up and listening, and then they need more pay than they currently get, and because otherwise they leave you and you've put all this work into them. But if they can get paid a living wage somewhere else, they go. Our results are pretty striking, though we don't yet have a control group due to the Stanford's General Counsel not letting us have access to the claims of patients, not ours. So we're working on that. But anyway, things are directionally exciting. You can see what it shows. But the last thing I want to do is talk about PAM results, because I actually think this is the proxy measure we should all be using, if not with this tool, with some tool like it. That if this changes in the way I'm going to describe, it probably means you're doing all the right things, and including saving money. So most of the distributions you see on this, level 2 or level 3 are the high ranking ones, and there's often a misconception in the safety net that everybody's level 1, and then they start administering the survey and they get a lot of level 2, 3s, and even some 4s. And they go, this can't be right. These are safety net patients. And it turns out it is right. That there's a lot of resilience and capability in any community, even people that don't demonstrate it well in exam rooms and no-show at appointments and things like that. Maybe no-showing is their way of demonstrating their activation at times. And so you can see the green on the left is baseline. The purple is what we discovered on follow-up 6 months later. And it's really the follow-up number that determines what has happened. The baseline is what it is. These are you can see everything shifted out of the lower 3 levels to level 4. So level 4, even though we started with a high level of level 4, and we're talking about, Nobel Prize candidates down to people that, scrub the floors, work in the cafeteria, mow the lawns in the hospital. And yet we were able to increase to level 4 a lot. This parallels what I've seen in collaboratives that I've been involved in with IHI and a big CMMI grant we have. And I'm not going to talk data about the CMMI grant, or I would have to use the slide Denver Health used yesterday about all the CMS disclaimers, so I wanted to leave that out. But basically, if you do this right, level 4 goes up precipitously and all the other levels go down. And then why does that matter? So this is what I'm going to end on, and then I'm going to ask a couple of questions that tee up things for later. So if you look at the far right, if you're level 1 and level 2 at both times, and this is a really elegant study done by Judy Hibbard in the Fairview system in Minneapolis, 33,000 people in this database with pre and post PAM, and some of them had financial data, so they had to extrapolate a lot of things. That it's quite expensive. If you go to the other extreme and you look at people that were level 4 coming in and were level 4 on follow-up, it's a lot of money less. Multiply that by 33,000 people and you're talking about a lot of money. If you move from 3 or 4 to level 1 or 2, it didn't matter that you came in at 3 or 4. It's where you ended up that mattered, and you still cost a lot of money. If you move from 3 to 4, you're slightly more expensive than being 4 at both times, but you're a lot less expensive than being 3 at both times, which is the third bar from the left. And then the most interesting one is the third bar from the right, which is moving level 1 or 2 to level 3 or 4, which is really where the action is. And you can see, if people were level 1 or 2 at both times, which is the far right here, and I don't have a pointer on this, but almost $8,400 a year. But if you move from 1 or 2 to 3 or 4, you save a lot of money, right? So we think that this data makes PAM or something like it akin to measuring beta blockers post-MI. And And we don't need to be doing the math that Denver Health is doing and everyone else is trying to do to show savings. And, we heard with Rita's presentation yesterday, where they did a randomized trial on 130 people in each arm and it didn't show savings. Well, if this had gone in the right direction, you would have been comfortable that if the numbers had been, 1,300 instead of 130, you probably would have seen something. Because we're working on, with the small studies and most of the, it's rare to see a project of 500 or more patients in any given place. We're working with numbers where it's almost a null hypothesis. It's almost impossible to prove financial effect. But if this is directionally right, if you're prescribing beta blockers post-MI, you don't have to show how many lives you saved. You just have to show that you did the right thing by prescribing the beta blockers. And the assumption is that the life saved followed. I think the level of science here is the same, and that this deserves the same role in, as an outcome measure. So with that, I'm going to stop. And then there are some questions about, should this be done in medical homes or do we need unique clinics? And I have opinions on that, but I'll wait for questions about it. Thanks.
Good morning, everybody. This is a real privilege to be here. I want to thank Ed and the Planning Committee for this opportunity. I think this has been a wonderful symposium, and I'm looking forward to the discussion that we'll have after my presentation. I'm going to take some time and really unpack the principles of family-centered care. We've really talked about patients and family-centered care, and I think it's really worth really digging into it a lot more because this is really on-the-ground work that we're doing here when it comes to care planning and coordination. So the AAP's Council of Children with Disabilities, in their 2014 statement, published a number of principles for care coordination that I'd like to reiterate. That care coordination should be patient and family-centered. It should be proactive, planned, and comprehensive. It should promote self-care skills and independence and emphasize cross-organizational relationships. Now, a lot of these have already been discussed and set up very nicely, so I'm going to take time to really go over the first bullet point here, which is patient and family-centered. So care coordination, when successful, addresses care across the entire continuum of health. And of course, it is driven by the needs of patients and families across the community. And a family-centered approach is universally regarded as critical for effective care coordination and planning. Now, when it comes to care planning, we're regarding this as really the action steps. As Chris said earlier, it is the ball that is thrown. And with the care planning, we talk about frequently assigned tasks and roles when a care plan is developed with input from patient and family. The challenge, I think, is how do we make all of this really effective? How do we make it translatable to on-the-ground health and wellness? And I'm reminded a cautionary tale of the parable of the elephant and the blind men. If you take the blind men in this parable and you leave them to the elephant, none of them can figure out what's actually going on, that there's actually an elephant in the room. And I would challenge folks to say that we have an elephant in the room. It's a healthcare system, and none of us can really see the whole of the elephant except for the families. They come very much the closest because they experience the entire healthcare system. Interestingly, I would also posit that the families are also the least empowered to be able to address the issues that the elephant is presenting. But our healthcare outcomes may best be effective if we take the approach of really understanding that there's an elephant in the room and understanding that our families face more challenges that I'm speaking as a provider than we frequently are aware of. We've shown care mapping diagrams throughout the symposium. I'm going to present another one that I know many of you have already seen this, but I think it's worth looking at Kristen Lynn's care map that she produced for her son a number of years ago. And the thing that strikes is, of course, just a number of circles that represent each individual component of the care system that she is managing for her son. You can also see that she has color-coded the care map on the left-hand corner, lower left-hand corner, for example. The blue represents more of the medical side, but that's only a small portion of the overall system of care that is being navigated for her son's health. So let's step back again and think, well, what exactly is a system of care? What is a system when we talk about systems? So a system is a range of services and supports that is guided by a philosophy and is supported by an infrastructure that, and I can't emphasize enough that the philosophy really needs to be family-centered and community-based. Now, when we talk about the infrastructure, let's talk about the requirements that go into the infrastructure for our care system. So we define a population, and for the symposium, we're talking about children with complex healthcare needs. We're talking about the defined components, and we've really mentioned a lot of this community-based services, the patient-centered medical home, and many other components. But we also need to be talking about the roles of the components and the relationships we develop with the components and the ability to adapt to these relationships. Finally, we should acknowledge the values and principles in the care system. And the principles of a care system of children with special health care needs, which has been published in a number of folks, including folks in this room, that they are responsive to family challenges, priorities, and strengths, that they are developed in partnership with constituents. They are reflective and respectful of cultural norms and practices of families. They should be accessible, the care should be affordable, and the care should be organized and coordinated through collaboration. So with all that being said, you see that patients and family-centered care just comes up again and again and again. And this is where I think it's important to really drill down on what exactly is family-centered care. What does it mean? Because it really gets discussed a lot without really understanding what is the essence of family-centered care. So family-centered care is really an approach to healthcare. It's really a culture that places the family at the center of all healthcare decision-making. And there's multiple considerations that go into family-centered care. It's part interpersonal communication, it's part facilities, it's part policies, and it's part leadership. And there's a lot of misconceptions we find about what family-centered care is. It's not, for example, simply asking in an encounter what families want to do. It's not about delegating or abdicating responsibility as a healthcare provider to families. Because a misunderstanding of what family-centered care can occasionally do a lot more harm than good. So a number of years ago, a group of us looked at a lot of family-centered care statements and principles, and this is a consolidation of the ones that just come up again and again. I want to leave this with folks to really just think about as we go forward in the discussion. So the first principle is that there is open and honest information sharing between parties. The second is that there is respect and honoring differences among families, between providers and families. There is partnership and collaboration, which I find is one of the more difficult ones to wrap our heads around, because partnership and collaboration also means that the provider community is also able to give up a little control in the healthcare encounter, for example, and say this is a collaborative process, not a I do this, we need to follow it process. Negotiation, which I think is also related to partnership and collaboration, but negotiation means that there rarely is in healthcare decision-making is there absolutely one way forward. There's usually multiple ways forward. And to be able to acknowledge that is a huge part of family-centered care. The last bullet says care in the context of family and community. And this goes back to the care map, is that our healthcare system is really, a lot of times our decision-making is designed around that little lower left-hand corner in Kristen Slip's map, but the families are really living in the community. If we talk about self-management, self-care, and healthcare outcomes, we need to acknowledge the care in the context of the family and the community setting. So I don't need to convince folks that we're not really there yet. Families in a lot of our literature talk about multiple unmet needs, needs that are really necessary to try to achieve healthcare outcomes, and that physicians routinely underestimate the family needs for community referrals, access to care, and interpersonal communication. These are some quotes. These quotes have been around for a while, but I don't think that anyone would argue that these quotes have, that what's stated in these quotes have changed even in the last few years. I feel like you guys give me this devastating news that my child has a lifelong disabilities and set me afloat in an ocean that said, okay, here it is, now go and do something about it. No one has ever told me about what is available really. Other parents telling parents is where I get 99.9% of information. We need stronger, more involved case management. We have a hotline for gambling and substance abuse for nothing for those of us who deal with day-to-day and sometimes minute-to-minute airway problems. Again, these are not new quotes, but I don't think that things have changed to the point where we are happy with where we are today. Families, of course, with children with medical complexity are many of them just pretty much getting slammed at home with the reported care burden. This comes from the National Survey of Children's Special Healthcare Needs. A quarter of families report at least 7 hours a week coordinating care. 18% report providing home care around the clocks. 57% reporting financial problems. When I talk with my own families about this, they think this is an underestimate. So. This is an interesting little table. This is a recently published study. A group of us sent out surveys among 3 different institutions for families who attend complex care services that are consultant models. And the part where I want to call your attention to is about halfway down. We asked families who attended these complex care services about the receipt of care coordination and management from their community-based primary care setting in the prior 12 months. And what we found was that the majority of folks are not receiving the care coordination, the chronic illness management, help referring to community services. When you get further down, you see help referring to family support services and networks. So when we talked about community-based systems of care, we do have areas where we can address and improve. A couple of years ago, I asked my own staff at Arkansas Children's Hospital, so what are the real-world care planning and coordination challenges that we have when we work with our families? And the staff is really a multidisciplinary team: social work, nursing, speech, nutrition, psychology. And this is the list they came up with: gas money, transportation, no permanent address, cell phones that are paid for monthly. We have a lot of that. Limited health literacy, parents who have very, very challenging home situations, multiple children with special needs. And I think this list dovetails with what Chris Feutner was speaking about yesterday with leverage points, and I think there were a number of leverage points that need to be addressed when we address care planning and care coordination. At the same time, I do think that innovative ways, multidisciplinary ways of addressing healthcare needs can be successful. This is the same study where we asked families in these 3 clinics, how is your health service need before and after we began a health service model that was comprehensive and coordinated. And what the interesting thing we found is that for every health service need, every single one of them went up. And it didn't matter whether these families were actually receiving that specific service. So I'll call your attention to respite care. None of our services in these clinics actually provide specific directed respite care, and yet that went up as well. So there is, I think, a mechanism here that's worth exploring. We also do not say that this is the only model that's possible. There are scalability issues and cost issues to be able to address, but I do think we may be onto something when we talk about a comprehensive multidisciplinary team-based approach to care. So what can you do? What can we do to improve the family-centeredness of care? And I think that at the very least, we need to understand the principles that it is really about negotiation. It is about partnership and collaboration. It's about understanding care and delivering care in context of family and community. Respect families. Refrain from judging. Don't use labels. The staff that I work with, they know that I'm pretty hot on saying that I don't ever want to hear the words problem parent or difficult parent. Because, and we get referrals like that, and I say, I don't want to hear that anymore, because that right there just puts it right there, it establishes a lack of partnership, being able to go forward. I do advocate person-first language, child with autism, not autistic child. And I think this behavior really needs to be modeled for all the folks that we work with to be able to establish that family-centered relationship with care planning and coordination. There are infrastructure steps, including the tools and templates, many of which have been discussed by other folks during this symposium. Developing families as advisors. This is, I find that this can be threatening sometimes. This is all about challenging, threatening. Folks feel that it can be threatening because it's like letting folks into an inner circle. And I think we need to challenge that more and more. We talk about families as advisors, but I would even go further and say families as partners and collaborators. So this is more than saying we're going to have a number of family focus groups. This is about having families at the table as colleagues. the part about assessing family needs routinely, this becomes more of a structural issue in care planning and care coordination about being able to implement routine psychosocial screening, routine referrals, routine, say, help desk or medical legal partnership. There's just a variety of models that have been implemented around the country, many of which we've heard them today. And we need to think from a systems standpoint how to really get them into be more routine work. Teach parents to be effective advocates. So I want to explain this a little bit more in that I'm inspired by this, knowing that by many of my clinical encounters in the setting, with the experience that I'm always discussing, this is what we can achieve if we work together. So one basic example is walking into a room and finding that a child is breathing noisily, is breathing a little hard, and as a physician, I know that the child probably has been aspirating for the last 6 months, and the parent doesn't say anything about it unless I ask them directly. And of course, when we try to unpack that issue, we find that the parent's been terrified at home, but thinks it's just normal. And I think that what we need to discuss is, what is the ideal healthcare experience? What's the ideal system? What is the ceiling? I think the ceiling is a lot of times a lot higher than what we expect it to be. We need to challenge ourselves. I think when we are family-centered, we really can learn from what are the needs of families, where do we need to go up to, and what are the expectations for care coordination and planning. There are tools that we can use to facilitate them, care plans, documents, templates. There's family networking support, which increases our knowledge and understanding of how to, what to expect out of care coordination and care planning. So in summary, family-centered care, the principles of family-centered care defines the system for coordination. It defines the system for planning. It informs the structures and processes necessary to develop the system. It can improve and streamline care delivery, but I think most importantly, it creates the culture that is necessary to effectively coordinate and plan care. And so my question mark, since we're full of question marks today, how is your culture for family-centered care? How well do you incorporate families, advisors, and partners? And how well do your tools, alerts, and reminders incorporate family-centered care principles? And those are the questions I would leave with you today. So thank you very much.
So now it's your turn. It sounds like as a panel we have started off the day with more questions than answers, and Chris started out with 19 questions. I think was it 19? 19 questions.
18 of the 19 were actual questions.
Actual questions. Alan ended with a big question, which is where does this system of care live? Is it in special clinics or is it in primary care? And then we just ended up with 3 more questions, and there's a bunch of questions. So I see that we have a lot of people lined up to give answers, and this is great. Yeah, right. So we all have our pens ready to take down the answers. So I'm going to start over on the left-hand side, since we usually start over on the right.
I'm Paula Lozano from Seattle. Thanks for a great session. This was really thought-provoking and exciting. My question is for Alan. At Group Health, we have tried to use medical assistants, not just for care coordination, but for health coaching. But I think some of the same issues apply in taking medical assistants out of their usual work and giving them a really different role in interacting with patients. And so my practical questions are, how do you keep them from being sucked into the vaccinations and the vital signs and rooming patients? Do you have a scheduled template where on Wednesday morning, this medical assistant is just doing care coordination and has that role protected? And the second question was, given that perhaps not all medical assistants want to get that extra training and want to have that role, or perhaps, that was our experience, that not all medical assistants felt comfortable with what we were asking them to do. Is there a way to give that opportunity for career advancement to those who are interested, and perhaps more might follow? So,
before you start, could we just sort of broaden the question to what's the role of MAs in family-centered care? And maybe what's the role of MAs in care coordination? So we just sort of take the role of MA as the question, and see what we can do with it.
So let me kind of work through that question, because there's a lot of different issues, and there are also, the licensure issues or certificate issues, and higher paid people who are lobbying to prevent MAs from doing a lot of these things in many communities. But it isn't that basically they have a panel, they have their own schedule. About half of their time is spent doing normal MA things during visits with their patients. So they're in the room throughout a visit. They're giving the immunization, they're drawing the bloods, they're doing everything, because the patients told us in the original design process, I want everything brought to me, and I don't want to go to I don't want to go to the lab to get lab, I want it drawn here, right? Don't make me go other places. And we have people with mobility issues where it actually takes, it's a big chunk of their life to get to the lab, kind of thing. So it's about truth in scheduling, and if you do that and create the right panel size, which for us is about 120, things start falling apart. So the question is, will Stanford, as we grow, give us the next person? I don't think every MA wants or can do this job, but there's a lot of people out there who can. And we hire for empathy. When we first arrived on campus, because we think we can train everything else, when we first got on campus, we put word out across the managers of the different clinics, send us your people who are getting in trouble for doing too much. Because Stanford had a very narrowly defined MA role. Room the patient, get out of the way. Smile, be polite, don't ask too much, get out of the way. And then ours are like the key person in the care team in many ways. So we hired people who fit the description, and the best description was, and the first person we hired was this amazing woman named Delilah Coleman, who is Puerto Rican, grew up in New York, was one of 9 kids to a single mom who brought in another 5 foster kids. So there were like 15 people in the family, and her job was riding herd over the 15, right? She is an amazing balance of wisdom, smarts, practical, and gets her, totally driven to get her work done. At one point, we exceeded the number because hiring was being held up, because our model is so different than the rest of the system that finance always goes, what are you doing? And what happened was we spent more in overtime than we were spending hiring the next person. And we were able to demonstrate that, so they gave us the next person. So I'll stop there.
The only thing I'd add to that, I know we have a lot of questions, is that our MAs, our patient population, probably about a quarter are non-native English speakers, maybe even a little bit more than that. And when you look at the culture and language ability of all the care providers across our spectrum, the one group that fits that need the most is actually the MAs. And so we're learning now, little by little, how to integrate them and take advantage of their many, many resources and their abilities. We're just getting started.
Yeah, I don't have much to add. We've got a lot of questions. I would just add that this is, I think in my mind, is really much more an issue of defining your care team and the various roles within a care team as they relate to patient family needs.
Good morning. Jeannie McAllister, formerly the director of the Center for Medical Home Improvement in New Hampshire. I'm now a Children's Health Services research at Indiana University School of Medicine. Wonderful panel, and thank you. I arrived in Indiana with an initiative going on there for children with neurodevelopmental disabilities and a real strong effort to improve the system. And families are in limbo between primary care and specialty care, multiple specialty cares. So we've been really working to try and address that, and had a lovely opportunity to use the Achieving a Shared Plan of Care, which Lucille Packard funded. My colleague Rylan Rogers and I have a holiday wish, really. We are being able to test out our holiday wish with families, where we are inserting ourselves in between this limbo and working with families to articulate their goals, what matters to them, their priorities, and have 3 months of care coordination to support that, we are using a relational coordination approach in that we do not want a care coordination entity down the hall or at a building down the street. We want it integrated with clinicians and care coordinators. So my question, in reading Jay's wonderful article, I don't know where he went, there he is, a couple of things that just jumped out at me. Most specifically is how can we get guidance and think about solutions for a locus of care coordination. I think Jay called it out as one person who steps up, who is responsible. For families who 20 years ago said they had 20 coordinators, and today say they have 20 coordinators. So how can we move towards a locus of care coordination that the system acknowledges and recognizes? And implicit to that is that they assume, as he also stated, that care coordination is core to healthcare and not something that goes when the budget cuts come. Thank you.
Chris, that sounds like you're...
Jeannie, thank you very much for that really great and difficult question. I think the biggest thing to help with that is to emphasize the nature of the team that cuts across care settings. And in order to do that, we have to have the policies and the payment structures to be able to do that, which is a little bit of a heavy lift, but I think it's really important. Because unless we achieve that relational coordination, things are just going to be fragmented in some other way than they are now.
Yeah, Jeff Goldhagen from University of Florida in Jacksonville, and occasionally I play Larry David on television. So yesterday I asked the question about sort of the Venn diagram where these issues of complex care intersect with palliative care. I'd go back just as a reflection that almost all of what we spoke about yesterday and started to this morning is in fact at that intersection between palliative care. But I want to now ask, less rhetorically perhaps, about the intersection with mental health. So I wrote our SAMHSA System of Care Initiative grant, which we eventually were funded for. I wrote it took me 3 times. I wrote it first from a medical perspective. It's a brilliant proposal, and they didn't fund it. And so I had no idea why. So I wrote it a second time with colleagues from mental health. Didn't get funded because of me. And then the third time I let them write it. And the point is that all of the issues we're talking about here have been dealt with by SAMHSA and have been dealt with in the systems of care literature and have been dealt with in wraparound and the codes that are now funded for wraparound and the targeted case management codes, which are funded by CMS and so on and so forth, by Medicaid and so on and so forth. So the question is, where is the intersection between all of what we're doing and talking about and what SAMHSA and Strohl and Freeman and systems of care and that literature that goes back 20 to 30 years, right, have already dealt with? And where is that intersection? And have you considered the intersection? And how do we take and learn from what's happened with our mental health systems of care and integrate it into what we're doing, not the least of which is they get paid for family peer managers. They get paid for youth peer managers, peer support folks. All of what we're talking about, at least as far as I can tell after the last 6 years in running the System of Care Initiative, is it's not perfect, but they're doing what we're talking about doing. So it really is a question. What has been the intersection in your work and others' work here with what happens with mental health and what comes out of SAMHSA and that whole environment?
So let me take a start. So first of all, medicine is about behavior. You know, that anybody who thinks it's about diagnosis and treatment you're born with a condition or you develop it during your life. It isn't that, it could be hard to diagnose some of the syndromes in pediatrics. But
We send those to geneticists.
yeah, but in the adult world, it doesn't take a rocket scientist to diagnose somebody with diabetes or asthma or those things. It's pretty straightforward. It's living with the condition as a patient or a family or a combo that's the struggle. So our job is actually behavioral health, and the medical stuff is almost trivial in the mix very often, except at rare moments. And then, so what we do is embed a licensed clinical social worker. We don't really need a psychiatrist, right? But what we've learned is that the story behind the low PAM, why people are PAM1, is something called trauma and childhood trauma and later trauma. And that turns out to be, I think, the hidden story behind all of our issues. That if we talk about health inequity, why is it not just by zip code? That question came up yesterday. And the answer is that there is trauma in certain families and there isn't trauma in other families living in the same neighborhood. So the assumptions, we know the associations with inequity, but the cause is what's specific to the individual or the family system. So it's about utilizing people at the point of care as a member of a team where she has, 40% of our patients are seen by our LCSW who does therapy. She's not doing, let me arrange a ride for you. She does that too. But the majority of her work is what's called trauma-informed care. I think and I don't see a lot of interest in that in psychiatry at Stanford, for instance.
Well, I'm going to step out of my facilitator role and just answer the question, because as CCOs, we actually put together mental health and physical health. That's part of the premise. And part of my personal journey is really learning from community mental health. And when you ask the question of why does community mental health have all this, it's because mental health was created out of deinstitutionalization, and the cost of deinstitutionalizing the chronically medically ill was a whole system of care. You couldn't, because you basically had to take a system of care that was institutionalized and move it into the community. So knowing that, what does it mean? It means that we have to re-educate policy at the policy level, that the cost of not dealing with a lot of the system of care issues for these kinds of populations is the same kind of cost, and really there's no difference in terms of what you need to do for the mental health population and these special needs populations. And so it's really a policy challenge for us to raise the level of understanding of the needs of this population to get that kind of coverage. But I think that, this is the age of ACEs. I mean, people have finally understood after 20 years what ACEs are about. And so I think it changes the conversation. It connects the physical health world, the physical health conditions, to what happens on the behavioral and mental health side. I mean, we could talk a long time about
Well,
this.
all I would ask for people is to go look at SAMHSA's core values and principles of systems of care, and it is what they did 20, 30 years ago that what we're talking about doing now.
Exactly.
Hi, I'm Eileen Forlenza, family leader from Colorado. Thank you for your presentation. I'm struck with just a couple of points and a couple of questions I want to ask. One is that we've been hearing a lot about family-centered care, and yet for those of us who have been working in the family leadership movement for years, we have found that that this is considered a soft skill and that the EQ is not valued. And so some of our work to design professional development institutes and leadership opportunities for families are not being funded as well as they should and could. And so what we have is this perpetual reputation, if you will, from the family side that just because I'm a parent of a child with a disability, I should be able to serve in an advisory role at my hospital. And we're setting families up to be in areas where their competencies are not being recognized for what they really are, and yet we can't get it funded. And even in my own hometown with Chris at Children's Hospital in Denver, we have a leadership initiative, and it was dropped after 2 years at Children's Hospital because they weren't seeing enough value to the institution of Children's Hospital versus the value at home, where families got these skills on civic engagement, and they're changing policies in their own school and in their neighborhoods, but we can't get the leadership funded. So that's one question. Similarly, I've always said that your budget is your policy statement. So if indeed our policy is we want an elevated presence and an activation of families and patients, why doesn't it show up in any of our budgets? Why can't we say that in every presentation we do with family-centered care that families are going to be co-presenters? And then what's it take to pay for those families to attend because they're leaving their day job as a school teacher or a lawyer or a restaurant owner and they can't just pick up and attend? Again, what does it take to really have a more authentic approach to the budget is the policy statement around family-centered care.
Sure.
So, Eileen, I could not agree with you more. I mean, I think those are well said. I think I really do think it's a culture change. It's a culture shift, and I think it takes. I think it continues to take time. But I am by nature can be very impatient about these things, and it does get aggravating to see sometimes it's slower than it needs to be. But I think that you raise. I think one point that you made is that all over the place, I certainly do see, families that folks want to be invited, or, groups and hospitals and practices want to also invite family advisors. Let's kind of take one step and say, okay, just having a family member, as a family member in the room as part of a team, and then they attend a few meetings, and that's where it ends. And there's a lot of reasons why that can happen. I think that, and it's anything is, work challenges, family times, child gets sick, but also the lack of orientation or training that can happen, and that's always an issue. And I think that's a huge issue right there. I don't think we've invested enough in the training or the orientation or the expectations for families, and I think that is something that we as institutions can and should recognize. I think we can take advantage of how long has it been, like 20, 25 years of Family Voices, longer, and and other family organizations, and that we have effective advocates that are already there. One of the things that we've explored is, we have initially, when we're launching something, gain more success by just having one of the representatives from the family to the families attend as a experienced, trained, connected family representative while we develop the family advisors and participants and partners within our own institutional setting. So they're not necessarily, parents of current patients, but they are professionals. And I think those are advantages we need to take advantage of more. So I do think it's a culture shift, but I think that the issue of having folks that really, as you said, we need to train more. We need to emphasize more on leadership, and I think that is something we should be pushing for.
Great. So we have lots of people want to ask questions, and we're going to run out of time. So I'm going to encourage questioner or people who are speaking to ask one question rather than not just to make, and we'll have one responder just to get through it on time. We have 10 minutes.
So Lisa Rosignol from Parents Reaching Out Family to Family Health Information Center in Albuquerque, New Mexico. And just to reiterate, I don't want to lose this point because the topic was so great, but the studies are coming in on care coordination from PCORI and NIH, and what they're all saying is if cultural if the culture is not right for care coordination, then it's just another relationship that the families have to manage. So I think that that's correct. And I think that we can actually just be really concrete about what this looks like, patient and family engagement. We can actually be really concrete. We don't have to be kind of ethereal about it. It's that you shouldn't be doing any policy without advising with a patient or a family. Period. And that could look like a stipend or something of that sort. And just the way that there are medical assistants that have great capacity, there are also parents who started in a degree in advertising and then had a baby that had a stroke and now work in health policy at the national level because they found this capacity that they otherwise wouldn't have. There's lots of us in that movement. And the benefit of having families is that they're not indoctrinated in systems. So you can go pay people to do lean projects and all these other proprietary things, or you can ask the people that utilize the systems, and especially in the complex medical care, high usage of systems, high dollar usage, with high consequences and high stakes, and they can let you know what the system actually looks like, and then what you do with that is really up to you. But that's an asset that I think is underutilized, and we can be very concrete about it. When you're going to do any initiative, find a patient or a family member and ask for their input, not just a focus group, not a survey. Ask them, have a conversation, go have a cup of coffee with them.
Thank you very much. Yeah, it's something.
So in 2006, we did a project when I was in Humboldt County as the chief medical officer of the county IPA with Judith Schaefer in the room leading, which was called Quality Allies. It was an IHI project, and it was about involving patients and families in teams. And our first patient was the absolute wrong person to pick, because all she could do was hear her own story, and she said it over and over and over and over again, and she didn't have a listening function. So we learned a lot from that. And we got past it, and it ended up with a collaborative around primary care redesign community-wide, county-wide, that 25% of the people in the room were patients. And what went away was the doctors saying, "You don't pay me enough to do a good job," which was a nightmare from my medical director perspective. And suddenly everybody was, what can we do for the patient? So it was transformational. To do that, we had to actually train the patients. And we paid them a stipend. They met the night before the collaborative to understand the topic, and every session began with a skit or a story or something from the patients, and you could just see the provider's jaws drop, and then the meeting went well every time. It's transformational, what you're describing. So we made it mandatory. That's how we got it in. It wasn't, it's a good idea, why don't you try it? Because they would have said no, the practices. We said, if you're going to be in this collaborative, you're going to do it. And they did. So I make it mandatory.
Culture change by mandate.
Yeah.
That's leadership, yeah. Right.
Jim Perrin, Boston. It's a wonderfully rich conversation, and thanks for all the great movement in this area. It's so much richer than it's ever been before. My quick question is, so where's the role of technology in helping you or hindering what you're doing in the area of care management, care coordination, et cetera? How much do the EHRs work or get in the way? And how much does mHealth and telehealth help you out?
Jim, thanks for a really, really good question. I think that there are increasing resources being put into interconnectivity between EHRs and stuff, but really the design isn't quite there yet. And I think the more, especially with telemedicine, the more we can invest in linking, maybe, I'd mentioned sort of non-healthcare system related care coordination. The more we can link that by whether it's video link or even, secure text messaging even, the better. But yeah, thanks for opening that question, because I think it's really important. But it is moving little by little.
I'm just going to say one more.
I think it's, EHRs are designed, they perfectly do what they were designed to do, which is to upcode and bill. The two pieces of the Epic system, the one piece of the Epic system at Stanford that really helps is the portal. So 50% of our interactions are through secure email right now. And then the one we lack is secure messaging that we're allowed to use, because there's a whole generation that doesn't do email anymore, right? And so I think the rest, it's all about communication tools. The rest of it is, someday it'll get better.
Thanks.
Peter Michael Miller from Marin, California. Thank you for wonderful talks. I spent my career working in multiple programs for children with disabilities in California. And I also spent my career working in public health. So with a combination of those, I've worked on enough care plans to keep me going for a long, long time. But I also worked with the Academy of Pediatrics on the early brain and child development activities. And from what I'm seeing here, and I may be wrong, is that there's a lot of discussion about ACEs, which is great. And there's a lot of discussion about family-centered care. But my question is, that seems to be focused on children and how to involve families in providing overall comprehensive care to that child. What I'm thinking of is, how about a family care plan where you're really looking at the entire family, where the issues of language issues, of poverty, of the father losing a job and being out of work, to fights that they're having in front of their children, to the 6-month-old who is at risk of being abused, et cetera, et cetera. What, is there anything that we can, experiences that we've had that say this is really a family-centered plan, a family care plan, not just a plan that's helping parents work with their children?
Huge issue. Yeah.
So thank you for those comments, and I completely agree. You know, on a micro level, you know, I think that is certainly in our service we've used social work to routinely to get at that, because that is part of their purview and part of their training. I do think that going forward, I think your points are very, very well taken as well. There is also, you know, there is some research looking at siblings and family as well. I think that's one area. You know, that we haven't really discussed within this, you know, within this session. I think in a setting where we certainly can accommodate the time and where we can accommodate the tools and the time, I do think we need to evaluate all of that, because that is part of the care system. And I think the key is to try to accommodate that so it becomes routine.
Is there anybody in the audience who has a family care plan? Really interesting, isn't it? I think partly it's the structure of medicine which breaks up a family. Interesting.
There is a thing called family medicine.
Alan and I have had this debate.
Alan, you know I'm a family medicine wannabe. Lee Sanders from Stanford University. You know, I'm struck by some of the themes across your presentations that all hit along the science of health literacy and health communication, which you might know I'm involved in. I'm wondering how we can better make use of those in our midst, particularly those of us who work at academic health centers who are experts in the science of health communication, often, by the way, from the fields of nursing, sometimes actually in the engineering quad as well, but particularly in the fields of nursing, in order to prevent unintentional disparities in care. Because that's what I'm seeing with patient portals and who we give our cell phone numbers out to. We might be unintentionally increasing disparities if we don't pay attention to the science of health communication. What your thoughts are on how we can do that?
Yeah, Lee, I think you raise a very good point. I think that the research that's been done is probably not as collaborative across disciplines as it should be, and anything that can be done to, you know, encourage, you know, multidisciplinary across campus, whether it's engineering or nursing or whatever, you know, we need to do more of that. I don't have any great answers other than, yeah, there's work to be done.
And then, you know, just I have a patient who's a PhD, you know, professor at a famous university, and I told him he had a hypertension at a visit, and I prescribed a med which he never picked up, and then I found out about 6 weeks later that he hadn't picked it up, you know, because we look at stuff like that, and the answer was, I thought about it and I don't feel tense, right? So don't make assumptions. Don't make assumptions. So we employ teach back. You know, basically, if they can't repeat to you what it is they're going to go out and try to do, you know, if they can't put it into words, you probably, it's not going to happen.
Great. Michael?
Michael Harris, I'm from Oregon Health and Science University in Portland, Oregon. I run a program called Niche, which is addressing the triple aim in youth with medical complexity. And I love the presentation. One thing that we've struggled with systematically with all our healthcare providers is the idea of observer expectancy effect. So everybody knows Bob Rosenthal's research many years ago. He's a clinical psychologist and then moved into social psychology. He looked at taking all his rats and labeling them randomly as dumb rats and smart rats. And of course, the smart rats outperform the dumb rats. And so I think we have a problem systemically that we think of these patients as dumb rats, and they perform at that level. And so speaking to MAs and care coordinators and physicians and other psychologists like myself and social workers, making a cultural change around expecting more of these people as opposed to less of them, I think is a simple thing that can be done in terms of boots on the ground changes for family-centered care.
Good point. Thank you. Do you want to just quickly?
Yeah, just quickly, I could not agree more. One of the things that I think we need to walk into a relationship with is that we acknowledge that everybody wants the same for the child, and the family is strength, and the family is support. And I think when we walk in with that approach, it sets the tone for everything. It does get back to the labels of saying, well, this is a problem parent, so to speak, which again, nobody will speak that into my midst. But I think you're absolutely right. I think that saying that families are strength and families are support, I think just goes a long way.
Great.
Jerry Lamb, Arizona State University. I'm also the co-chair of the National Quality Forum's Care Coordination Standing Committee. Chris, I think this question is for you. It strikes me that both yesterday and today we're situating care coordination right within a context of effective teamwork. And I'm wondering if you see opportunities to really bring together and accelerate both care coordination and teamwork by bringing together all the work that's going on pretty much in silo between team science and care coordination, and also bringing in the new National Center on Interprofessional Care and all their research initiatives. What do you think about bringing those together to move things forward more quickly?
Sounds like a great project proposal. Honestly, I think the world of complex care and the world of care coordination hasn't quite looked at the team science stuff that's going on yet. I think it's not there yet, but let's do something together.
And just speaking to the silos, there's a woman at Stanford named Kathy McDonald who's done research on care coordination, can measure it, great research. Here we are at Stanford Coordinated Care as our clinic, and we're on the same campus. And I didn't meet her till we were co-presenting in Ireland a few years ago. So I couldn't agree more.
So last question, last comment.
And we have one right after me here, sitting down.
All right.
I'm Danny Armstrong from Miami. A quick comment and then a question. The comment is that we talk about family-centered care and care coordination sometimes as a homogeneous entity. I've been privileged to live in a community where only 15% of the people look like me and speak English. It's a minority-majority community. And being able to make sure that in all our considerations that we think about the variation of what makes up a family. Parents don't agree. Parents and grandparents don't agree. Parents and cousins don't agree. And neighbors don't agree. And when we think about families, that all comes into the consideration. So we need to think about that cultural component. The bigger question for us is one that concerns me every day. I had the chance to work with the Academy and the American Psychological Association and David Satcher and his report on children's mental health services in the late 90s. And one of the things that came out of that report was that there was approximately one provider in psychiatry, all of psychology, school psychology, advanced practice psychiatric nursing with focus on children, one provider for about every 900 diagnosed children. And that did not include the ones who didn't meet diagnostic criteria. We've had a workforce shortage there for decades. It's on everything. But we also have workforce shortages in almost every specialty area except neonatology and cardiology. And so when we think about designing these systems and how we coordinate the specialty care with practices, primary care practices, while endorsing the medical home concept, have, for financial reasons, really went under a volume-based practice model. We need to think a little bit about where's the workforce? What do we need to do in terms of training for this kind of new model that we have? You mentioned, I think at one point, we talk about workforce, but maybe I could put to the panel, what are your thoughts on what we need to do, given that the time lag is usually 10 years from the time you have the idea?
Actually, I'm going to ask us not to respond to that just because we don't have it. We're on our break, folks. So if there's one more question, comment, because I think it's a great question. I don't know that the panel can effectively answer it in the time we have. So.
Oh, sorry. Multiple mics here.
Thank you. I am with the National Disability Rights Network, and I wanted to ask what you all are doing to actually train your providers so that as you meet this new model of care, they can be more informed about what constitutes independence of the individual with disabilities and of the multiple home and community-based services that are available, because so much breaks down in a care plan if the team itself has the stigma of low expectations, simply because they're not aware of how far our infrastructure has come from institutions only to home and community-based service possibilities.
Do you want to take that, Chris? Yeah, thank you very much. That was a great bunch of questions. You know, I think a lot of it comes back to the training and the role modeling that we do for the different trainees. One thing that we've tried to do is set our primary care sites up so that the students and other learners see everybody. They see the family members, they see the nurses, they see the doctors kind of all together. It's sort of an all teach, all learn kind of model. I think many medical schools are getting into patients as teachers, which was certainly not the case when I was in medical school 25 years ago. So there's a lot to be done, but I think the more we emphasize the larger team, the better off we're going to be.
Just to quick response. I get to teach medical students from kind of very early on through the end of their experience, and they come in okay. All they bring is their empathy and their ability to listen and collaborate, because they don't see themselves as expert. It gets systemically bred out of them, and there's this thing that happens around us versus them that's a psychological defense when you start reading about all these horrible diseases, and every one you think you're getting. That then you say, well, the patient has a disease, and then that's how you protect yourself psychologically. It takes a lot of work to prevent that damage from happening. That's what.
I want to thank our panel and the audience. Great conversation. I look forward